Okay, let's start the presentation. Hello friends, thank you all for joining us today. We are excited to see such a fantastic turnout. Since today is the first day of Endometriosis Awareness Month, we couldn't miss the chance to show our support for everyone affected by endometriosis. I'm Tanuj Satish, the marketing head of PWCRI, which stands for Precision Women's Care and Research Institute. I'm thrilled to introduce Karan Salunkhe, our operations and technology head. Karan will walk us through the test and share the amazing technology behind the test. We are honored to have Dr.Sandesh with us today. Dr. Kade is highly respected gynecologist who practices in both Abu Dhabi and in India. He is the director of the Advanced Gynecological Institute in Abu Dhabi, which is dedicated to advanced endometriosis treatment. Dr. Kade's achievements speak for themselves. He's performed over 10,000 surgeries, including more than 150 robotic surgeries. His expertise and passion for endometriosis care have truly set a high standard for treatment in India. Over the past few months, I've had the privilege of talking with him about the critical issue of delayed diagnosis and the immense pain and suffering that so many women and adolescents have to endure. His insights have been eye-opening and inspiring. It's an absolute honor to invite Dr. Kade to share his thoughts on this groundbreaking test. Without further ado, Dr. Kade, the stage is all yours. You can speak.
At the outset, let me thank Karan and Tanuj. Congratulations and appreciations to both of you for all this hard work and all the striving you have done to bring this test to India and all our patients here. Actually, but I'm going to be very, very critically evaluating this test, which has come and which will be available very soon in our clinical practice so that we can use it for our patients in India. Today, I'm going to share my views on endometriosis. Then we will go through the technology that has been available to us now and whether this really has a level of evidence so that we can actually accept it in our armamentarium to help our patients. But there are a lot of new terms in this presentation. So before I actually begin my speech, I would like to clarify some terminologies. Now, the first terminology is signature. So here on the screen, you have a signature. So can you identify it? It's very easy. It's M.K. Gandhi, Mohandas Karamchand Gandhi. So this is a form of a signature. Now you can have different signatures. Now here you have PQRST waves. Now what is this signature? For medical students, it's very easy. It's a signature of ECG, echocardiography. Likewise, for obstetricians, what is this signature? There's a systolic wave and there's a diastolic flow. So this is a signature of uterine artery Doppler. So there are different signatures. And what we have to be ready now in this future is this signature. I'm sure this is going to be a very new thing for many of us here. And this is the use of artificial intelligence and next generation sequencing and then deriving this signature. It's a very complex thing, though it looks very colorful and nice, but it's a very complex thing and it is actually very, very robust and sturdy and very stable to give our diagnosis. So let us see how we have this in our clinical practice. Okay. So my topic today concerns this signature is how genomics and artificial intelligence are redefining the future of our clinical practice. And we are speaking in context of endometriosis. I bring greetings to you all from Burjil Medical City, where I am the director of the Advanced Gynecological Institute. And here we have a dedicated endometriosis center, which is in collaboration with Horace and Benjamin's center in Bordeaux, the Ifimendo Middle East Clinic, catering to the whole of Middle East and South Asia. So, greetings to you all from my workplace, Burjil Medical City. So to begin with, let us just go through the incidence of endometriosis in India. Well, it's very, very disturbing. The endometriosis affects women between the age group of 15 to 50 years. Okay. And the number of patients suffering from endometriosis in India alone is 4.2 crores. And this is 25% of the world's endometriosis burden. So it's a huge task we have to do in our practice is to cater to these women with severe endometriosis. And these women, the apathy is that they do not get their diagnosis in the first visit. You can see 40% of these patients need to visit the doctors for more than 5 to 10 visits, and then they get heard and then they get the diagnosis. So majority of the times the patients feel that they are dismissed, ignored, or belittled, and so they feel very disturbed in their life. So what we have to understand, and most important, is 74% of them will receive a misdiagnosis as well, because it's a symptoms are mainly pain and it can be overlapping with other diseases. Majority of the patients are diagnosed as irritable bowel syndrome, irritable bladder, or chronic pelvic pain, or even psychosexual complaints. So we have to understand that this disease is a chronic one. It affects from her 15 years to 50 years. We have to reduce her sufferings. We have to reduce her wandering. We have to reduce the investigation she undergoes. And also we have to reduce the wrong diagnosis which she receives many of the times. And so this really affects a girl in her school. She misses her school. In college she is not able to, concentrate, and she is actually left behind in the career as well, or in her marital life, also the personal relationships, and it goes on. The list is endless. So the priority is actually early diagnosis. And the incidence of endometriosis keeps on increasing. So this very good paper in 2019, which highlights that the number of menstruations in a woman's lifetime would actually determine the incidence of endometriosis. So as we can see in the new era, the number of pregnancies are reduced. The first pregnancy is late. So there is less breastfeeding. All these factors actually lead to more cycles or more menstrual cycles, more ovulations, and the number of ovulations will determine the endometriosis incidence. And that's why, with rising trends of the assisted reproductive technology, super ovulations, all this is leading to the increased incidence of endometriosis. Also, you can see the disease spans from puberty to menopause. So it's a chronic state. And the goals of our treatment have to be like four goals mainly: to avoid the evolution of the disease to severe forms. So we have to act early. Secondly, we have to pick up the cases which can go into infertility or reserve ovarian reserve failures. So we have to be mindful and careful while we are treating these patients with our surgeries on ovaries particularly. We have to do a complete surgery. There should be no 5 or 10 surgeries as usually we see in our practice. It should be the first surgery, the last surgery. You do maximum workup and then give her the best options, do the maximum excision and avoid recurrences. And most importantly, these surgeries, because they are multi-organ involvement, also they are in the vital organs, there has to be very vigilant on the complications that can happen or the post-operative sequela that can develop. So we have to be very careful. And so early detection remains the keystone or the cornerstone. And if you can see, majority of the patients, the distribution of the patients of endometriosis is in a pyramidal fashion. So you have more patients in the base of the pyramid. Okay. So majority of the patients are in the early phase. And what we see in most of our the social media or everywhere is the very advanced surgeries being relayed. So the patients keep on decreasing towards the tip of the pyramid, but you have a huge load of patient burden which is lying down at the base, which has to be picked up. And why there is a big amount of patients there is because the lesions are very small. They are not visible they are not palpable, and that's why we miss a lot of patients. So we have to be careful in identifying the bigger circle at the base, that is the majority of the patients in the early stage. And while the rest of the patients currently we see in the multidisciplinary team are the ones where the endometriosis has spread to the rectum, to the nerves, to the ureter, or to the diaphragm. Very, very wise sentence given by Jack Donay, that nobody is born with stage 4 endometriosis. It means that we all are at fault, including the parents, the doctors, and also at times the patients who sometimes ignore the symptoms. So everyone begins with stage 1, and right under our nose, they progress, complaining, getting ignored to the stage 4 endometriosis. So, what exactly is happening? So, here I am trying to suggest a hypothesis which a majority of the doctors to agree to, where there the hypothesis is that there is a crossroad at the age of 20 years. Suppose the menstrual cycle begins around 13, 14, and then she starts to the menstrual cycle sets in. Meanwhile, what happens is the endometriosis symptoms start, but nothing is seen. These patients keep coming to the hospitals and they are progressing. But what happens after 20 is suddenly these patients take a turn. From here onwards, the patient of a peritoneal endometriosis, simple one, can take a turn to develop an ovarian endometrioma, or she can go in for a large nodule into the rectum, into the ureter, or up to the nerve sciatic. So, all deep infiltrating endometriosis, or there could be chances of infertility. So, at this crossroads, we have to act. And if you see majority of the series of most of the experienced surgeons, you would find that if you take the series of Horace, where they do mostly the rectal surgery at around the age of 30 to 35. So basically, the patient began with stage 1, and around 35, 30, 35, they get operated for a very, very severe disease. So it is this stage in which we have to find the diagnosis, treat these patients, and prevent them from going into a very severe condition. So, what are the tests that are available for us to do this service to our patients? Well, what we employ in our current practice is a good history taking. There are a lot of papers in very renowned journals, also Lancet, where you have from Charles Chaperon, all these people have given a questionnaire. So they have given some questionnaire, there are some algorithms, and they have tried to diagnose these diseases. So a good history taking is available to us. Then the next one is the imaging technology, that is the ultrasonography and MRI. And then you have some blood tests or the blood biomarkers which are available. And finally, 25%, the majority of these patients, they land up with an invasive test, that is they undergo laparoscopic surgery. And so here we want to avoid this. And also now latest is the availability of this test. What we have understood, in spite of all these technologies available to us, we have not been able to reduce the delay in diagnosis. So it remains the same. So what is happening is these modalities which are available to us are not perfect. And that is what has been already shown by this questionnaire, that it will not be enough to identify the patients just on the basis of history taking, because the symptoms of the patient do not correlate with the lesions. Sometimes a very large nodule or a very advanced disease and the patient is asymptomatic. Now, this questionnaire will fail to identify an advanced disease also if the patient does not have symptoms. So, the symptoms are based on, the diagnosis is based on symptomatology. So next is the sonography and the MRI. And what Eshrey has told us, majority of the lesions are not visible because the visibility of the lesions will depend upon the size of the lesion. And to begin with, majority of the patients are in the small lesions where there is a failure or negative diagnosis on ultrasound. But and then ESHRE gave us the guidelines. Even if you have negative imaging, you can, on the basis of clinical history, you can go ahead with the treatments, and that is try to, because we were not able to really give a perfect diagnosis to our patients. Same happened with the laparoscopy, because you need experts. Lot of lesions are there. A majority of the doctors have not seen these lesions. They fail to identify these small lesions because their eyes will not see what their mind does not know. They have not seen these type of lesions, and they will always fail into identifying these diseases. Secondly, sometimes you find lesions, you take a biopsy, you take excisional biopsy and send it for checking. The histopathology comes negative. Now you still have to go ahead with the treatment of endometriosis and not accept that the histopathology is negative, so this is not endometriosis. So there are a lot of dilemmas in diagnosing endometriosis. So what is the solution we have now? Is the solution is the biomarkers, and this has been there for many years, but that was not enough for us because it was not a very specific and sensitive. So before I start talk about this technology, I will again take a small break here to make you understand, like how I explained about the signatures, is how the artificial intelligence works. So basically, I'll just give you an example. Can you identify this gentleman? I think majority of us in India identify him. So, but I want you to understand how an artificial intelligence or the technology identifies him. Not because they have seen his movies, but because of the eye distance, the nasal bridge, and multiple sites are taken into account. So it might be taking into some 100 points and then identifying. We are now believing, yes, he is Amitabh Bachchan. So we have to understand how this artificial intelligence is using the technology to identify. And we are believing it upon it because nowadays we are even transferring money, funds just on the basis of facial recognition. So we have to understand how the technology helps us to identify or create this signature and identify, yes, this is the sample of a patient suffering from endometriosis. Okay. So the technology employed is next generation sequencing and machine learning technology. Lots and lots of data has been fed, algorithms have been fed to these machines, and now they can pick up and analyze a huge data and give us the exact diagnosis. So we will just go ahead into understanding how this technology works for us. So, first thing is we have to critically analyze whether this test is simple, whether it is non-invasive, and whether it is stable, reproducible, and accurate. And most importantly, a test, if somebody comes up with a test and asks me to use it in my practice, I would ask what is the sensitivity, what is the specificity, or what is the area under the curve of the sensitivity or the accuracy, and that has to be above 95%. So what is claimed by this test is it is above 95%. So let us just understand this, how this test has evolved and whether they were very scientific in bringing it up to us, because we will not just accept it because somebody says about it. So we have to understand, for the past 10 years, there have been a lot of research in identifying the biomarkers. People have studied blood, tissues, stools, vaginal swabs, or even urine, and then they have tried to identify different biomarkers like glycoproteins and the angiogenic factors. Also, there are like microRNAs, DNAs, microbial markers. So, based on this, but unfortunately, none of these tests were very sturdy or robust to go and be used in the clinical practice. So for research purpose, there could be no limitation to finding out how many biomarkers are there. But when you want me to use it in my practice, then it has to satisfy certain criteria, and you should include in your studies that understand the type or the phenotypes of the disease. Now you cannot compare oranges with apples, because the apples also could be of different varieties. You could have a green apple, you could have a dark or a small apple or a large apple. So likewise, the endometriosis also has different phenotypes. We have peritoneal endometriosis, we have ovarian endometriosis, we have the deep infiltrating type of endometriosis. So the sample size should include all the stages of endometriosis. It should be able to pick up every stage of endometriosis. Secondly, when you are taking patients on the basis of symptoms, the pain, which is the main symptom, then there are many other gynecological pathologies which can produce pain. So, have you included those patients in your study which can produce pelvic pain? So, then it becomes more specific. Yes, this pain is specific because it is because of the endometriosis. So, we have to have the other comorbidities included. And most importantly, when you say this is a good test, then you have to show me it is good in comparison to what. So currently the gold standard for endometriosis is laparoscopy. So the test has to be better than imaging and laparoscopy. So only then we could use this test in our clinical practice. So what is this test using? This test is actually using the microRNA technology. Now, what is microRNAs? So we have to understand that in the DNAs, they are like multiple nucleotides. And when you break down a small transcript from that nucleotide, and when you have a a tissue which is having like about 20 to 25 nucleotides, then it's a very tiny RNA. And so these are called as the microRNA. Now, these microRNAs are actually in a dormant stage like. So when they are dysregulated, then they can either get upregulated or downregulated. Usually, what happens is the DNA will undergo transcription and translation and develop into a gene for its expression. Now, when there is a dysregulation, the microRNA will come and silence this messenger RNA. So, if you understand that the genetics are at the origin of tumors or also for the treatment purpose. So, we have to actually understand where these microRNAs play a role. They will prevent or silence this expression of these DNA genes. And so, it could be like stopping the development of a tumor or actually stopping them by sending the drugs to that tumor and treating them and identifying the response to them. So we have to understand that these microRNAs have to be identified, and only then they can be used as a biomarker. Now, how many microRNAs have been identified? To date, around 2,600 microRNAs have been identified in human body. So they are present in all the fluids of the human. They can be in the blood, they are in the peritoneal fluid, they are in the saliva. So we can identify these microRNAs, but we have to choose which method to use, because we want the method also to be non-invasive. So salivary microRNAs are actually a better option for us to use in our clinical practice. So in 2022, they came up with this first study. Now I'm checking into what level of evidence is there for us to use these tests. So this is the first paper that was launched by them. And here you can see they used 200 patients' salival sample to detect endometriosis. Now, these patients all had the symptomatology of chronic the pelvic pain. So they were suspected to be of the endometriosis, and these patients underwent the diagnostic attempt with MRI and sonography. And also, because the diagnosis was not clear, they were posted for laparoscopy. It is here when these patients were offered these salivary tests. So in this case, what was analyzed, all patients underwent the analysis of the full human microRNome, which means all 2,600 RNAs were identified in each and every salivary sample of these patients. Okay, and then they tried to actually create a signature. And they had included all the variety, the early phases, the late phases, or the comorbidities that can give rise to the pelvic pain. And these patients were included in this study. Now, to actually use a biomarker in clinical practice, the biomarker has to be specific to the disorder. Okay, there are criterias given which are called as the famous Agrawal's criterias for biomarker use in clinical practice. Like I said, in research, they are a bit lenient, but in clinical practice, it has to be specific to the disorder. It should diagnose the earliest stage of the disease. It should be non-invasive. It should be stable, clinically reproducible, and associated with known or potential pathophysiological mechanism. Means if you take the mechanism of endometriosis, you have the cells going in, the cells adherence, the inflammation, the angiogenesis, the apoptosis. All these are the pathophysiological mechanisms. And there's an excellent paper given by Kavita Panir, a review article, which talks about microRNAs in each phase of pathophysiology of endometriosis. Now, what has happened is collectively these microRNAs have been analyzed. And here they have gone much steps ahead into analyzing a huge number of microRNAs. A few were known, or the majority of the earlier attempts were because the microRNAs used were very few. And that's why there was no specificity in identifying the disease. Just taking inflammation as a marker of endometriosis and giving us a report on basis of some 5 or 10 microRNAs would not suffice, because endometriosis is more than just inflammation. So you have to include all the stages that happen in an endometriosis and try to see if all the biomarkers are involved and then come up with a test. So it has to be a very, very robust methodology. And what happened with these salivary samples is, if you see a salivary sample which is analyzed, so this is where the gene sequencing comes into play. Okay, so each the microRNAs are delivered from the gene sequencing methods. Now these are sent into the machines, where every salivary sample will develop a sequence. And if you see, there are around 13 to 40 million, average 15 million reads per sample. So for each patient, they develop such a huge data. Now, this huge data is impossible for humans to analyze. And that's the role of artificial intelligence, where this huge data is supplied to the artificial intelligence, and with the help of algorithms, in a short span, they can actually analyze these reports. So if you see this signature which has developed is after analyzing 2600 microRNAs in each sample, and then 109, looking out for those 109 microRNAs which are specific to endometriosis, and not even like deleting a 4 or 5 out of the 109, let's accept it. No, when the all the 109 microRNAs are present in those particular sequences, then only they get filtered throughout, right from the top red to, as you go down into the last sequence, you can see the signature down, that is the green signature. And when you have this signature, then you call it as a case, yes, you have endometriosis. So we are so fortunate nowadays to have an answer which is yes or no. This is so important for me in practice, because the patient just keeps on coming back to the hospital and asking about the diagnosis. The lesions are so small, not seen, not palpable, and actually the patient keeps complaining and returning to the OPD, thinking that I'm ignoring her, I'm not giving a diagnosis. So finally, now we have an answer, yes or no. If it's no, we can clearly tell the patient, you are not suffering from endometriosis. This could be something else. Kindly actually look into for those clinics where you could find an answer for yourself. So this is very, very important for us in our practice to find yes or no. And when you have an answer, And like if you remember the crossroad which I explained, if I have an answer that okay, this girl is going to have endometriosis, then I will be immediately worried what type. And now the next generation or the future would be about the phenotypes. So here you can see the first paper, the sensitivity reached to 96.7%. The specificity was 100%. 100% meant yes or no in our clinical practice. So this is how they selected the first patients. Now, like I said, we are going to be very critical in analyzing this. But this paper is only from the company. So they could say anything, isn't it? So they have to do a multi-center trial. So from the first test, they claim they have a sensitivity or the accuracy of more than 95%. And this use of artificial intelligence and the gene sequencing was more accurate than MRI alone or ultrasound alone or MRI and ultrasound combined. So it's a fantastic test. But who is saying this? It's the company saying this. So the next step we wanted was, why don't you do a multi-center trial? And they did it the next year itself. And they added the patients 5 times. 1,000 patients were included. And it is done in different centers in France. So now we have that, like this is the interim result which I am showing you on the screen. Actually, what I got to know from Sofian Bendifala. Sofian Bendifala, you must be seeing that name frequently. He's an excellent surgeon, actually, with of endometriosis. Attended a lot of his surgeries and had a word with him in Bordeaux when he used to be there for the congresses. So, excellent surgeon. He went into this research and PhD into actually finding these signatures, and with the help of this company Ziwig, they all with the clinical analysts and the clinical mind of Sofian and his team, they could really achieve these fantastic results. And here you can see the interim results. And when I spoke with them, the final paper is in under publication in the final review. So they are very happy and very hopeful about these results. So next, when they did the interim results, also it was about 95%. Okay, so this test confirms the diagnostic performance. It confirms the stability, reproducibility of the microRNAs in the salivary tests. So basically now, the when you have the diagnosis, it can be applied in our clinical practice to do an early diagnosis, to take action against it. Secondly, is to improve the overall clinical pathway. Nowadays the patients are not getting diagnosed, they are utilizing a lot of medical armamentarium, and so it's the cost or the burden comes on the country. And so we need these patients to be diagnosed and immediately put into treatment, prevent their progression of disease, also prevent the repeated use of the modalities unnecessarily, and waste of all the technologies. So we need the early diagnosis on priority. And next is the optimizing their management, which actually could best happen if they give us the answer, yes, you have endometriosis, and with the other algorithms, yes, you are going in for this type of phenotype of endometriosis. So where should we utilize this test in our clinical practice? Where is the place of this test? Now, suppose a patient comes to us in the clinic with the complaints of the signs and symptoms of pelvic pain and suspected endometriosis. Yes, you do your clinical examination, your good history taking, and your ultrasonography and MRI. And if you are able to diagnose it, like endometrioma, the ultrasound is almost to the tune of 99% diagnosis, okay, in majority of the hands. So we don't deny that ultrasound is a good modality to diagnose endometriosis, but it can diagnose a little later. So endometriomas are very well picked up. So you, okay, you diagnosed, you put her into treatment, that is the right side of this slide, and we are not bothered about this. Okay, you have deep infiltrating endometriosis, you needed you missed it on ultrasound or picked it up, and then you did MRI, you found yes, she is a case of endometriosis. Fantastic, go ahead with the treatment. These are anyways late cases, and they are unfortunate. So we want patients to be picked up early. So then what you can do is you can do this test. instead of doing the surgery or the laparoscopy, instead of a surgery, do a non-invasive test for that patient. But some doctors would say, no, no, I for years I have been giving them empirical treatment. Okay, so you can go in with the OC pills or your whatever treatment form you prefer. But a lot of times, these patients could be contraindicated to hormones. They could be like non responsive to the hormones, or the patient themselves don't want these hormones. So in this case, again, you have to come back and do this test. So this is a like the place for me in the clinical practice. Instead of going invasive, instead of going blindly attempting for hormonal treatment, I would rather prefer to do a endo test, confirm the diagnosis, save her time, give her an early diagnosis, and let her make her choices. So, this way, actually, this test can be placed in a very early stage where our history taking or the imaging or the clinical examination fails to identify these patients as endometriosis. And the next big thing is the unexplained infertility. In unexplained infertility, we usually have around 10 to 30% of patients with unexplained infertility. And we know the incidence of endometriosis patients with infertility. So if your patients are infertile and are because of the early endometriosis, then you have not done this test and you are going and telling the patient that you are unexplained. Maybe that it is unexplained to you because you did not do this test. If you can do this test and identify the patient, it will save that embarrassment, saying that it is an unexplained thing. So we can actually find out a lot of, because that's a huge chunk of patients who suffer from infertility and endometriosis as well. So I would say that now we really are happy to have this test, which is non-invasive, very accurate, very reliable, and also it is employing a very strict criteria and giving us a very high sensitivity and specificity. So this in the take-home messages, I would say the endometriosis detection allows us for fast, reliable diagnosis. This test would allow for a reliable diagnosis. It would enable us to start the early treatment, and also it would reduce all the burden on the patient as well as on the society. So this is just the pathway through which the test goes through. I think Karan would be in a better position to explain us later. How the salivary samples are collected. There's a questionnaire to be filled. Those samples would be sent. Now these samples are sent. There is I mean, salivary samples can be sent in room temperature. Okay, so they will be sent to France at present. There they will be undergoing the reliable, stable biomarkers, whether it suffices the criterias. Then they would go into the sequencing machine. The microRNA sequencing would happen, and then it would be fed to the algorithm analysis, the artificial intelligence, and then the test is available for us. And this is how you would get a report: yes, no, or equivocal. Okay, so these are the very, very simplified, very to the point method of diagnosing endometriosis. So I think now it won't remain that enigma. For years I have been using that slide. I think now hopefully I will delete that slide from all my presentations. It's an enigmatic disease, it's a complex disease. Everything is getting explained with this technology. This is how the future of artificial intelligence and genomics is going to change in our clinical practice. So is this the game over for now? You have diagnosed and this is enough? In fact, it has led or opened the doors for more technology, more innovations. So what are those? Now this can be used even in, like they will be trying to use it in adolescent, because that is the earliest when the disease or the smallest or the lesions that should be picked up. Okay. Next is the microRNAs are at the functioning of the DNA or messenger RNA into a gene expression. So if you can hit that tissue with these microRNAs carrying the medicine or carrying the diagnostic tools, then we can actually identify, diagnose, or treat. So it can be used as a predictive tool in future. And most importantly, if it can give me that if this patient has endometriosis, she is likely to develop the rectal endometriosis, then I would convince her parents that you are in for a very dangerous play. You should be on the medications. Now the patient will not have an option. If I can have an answer that she is going in for a very severe endometriosis, that like how the patients of diabetes, they don't ask you question, I don't like insulin or something, they have to take and they take it. Likewise, we have to convince our patients that you have endometriosis and this is the treatment for you. If you don't take it, you are risking your own life. So if I have this pathway or the methodology, now there are recent papers from this company where they are identifying which patients. We all have understood that we say endometriosis is not equal to infertility. That's correct, because not all patients of endometriosis are infertile. Many of them conceive. So who are these patients who are infertile? And there is another signature that has been designed using these biomarkers for to identify these patients who can go up into infertility. And before they develop these endometriomas, before their AMH drops, these patients can be convinced, or they are the most ideal to go in for egg freezing. Okay, so this is the technology that is coming up, and it is going to, that's why I say it's the game is over for endometriosis. It's like a checkmate for it, and we are going to understand each and everything. Probably I this would be too much of a statement for now, is the even the next generation would need not have to learn all these complex surgeries, because if you don't allow these pathologies to happen, who is going to operate on what? Okay, so I think this is the best expectation I am raising from this test. So I think Karan will explain these tests to us. And finally, again, to like to bring up the points is, now we really don't need to really for gynecologists to go ahead and learn all that radiology and try our best and all that. If we can get a test which can immediately diagnose, utilize that time for the other patients and for other good work for in our clinical practice. So diagnosis can be done even without a laparoscopy. Such a boon. No need to actually put the patient under knife and have a diagnosis for those patients. Reduction in the delay on the development of the severe forms of the disease, and tests positive for different types of endometriosis will make the patient aware that she is in for a major pathology and she can take care of herself, and actually she can modify her schooling, she can modify her career or her reproductive life and take actions according to it. Usually, if you see majority of the patients, like it was shown by Horace, the rectal endometriosis gets operated by 30-35. So if you prevent it in that period of cross road, then like what we see in our practice, if I do a laparoscopy for a elderly or in a tubectomy patient, family planning operation, and you find endometriosis, then we don't scare that patient. You have endometriosis. Now, by her age of tubectomy, if she has not developed a rectal endometriosis, she probably will never develop it because she is not a case of rectal endometriosis. So we have to understand that's a different phenotype. That's a different patient. That's a different disease altogether. So we can identify this in our clinical practice. So, and also take corrective actions, preventive actions on the patients of infertility for a right timely the egg collection. So I think now thank you very much for your patient listening. And once again, I am so happy for Tanuj and Karan for bringing in this technology for us. I'll just stop sharing.
Thank you, Dr. Sandesh, for your insightful presentation. I'm sure this session was incredibly informative for everyone eager to learn more about this diagnostic method and its efficiency. Before we dive in into the details about the test and its application, I would like to take this moment to express the gratitude for the overwhelming response to this webinar, where we received a multitude of questions, and we're still receiving them right now in the question section from all of you. And we have carefully selected a few of them to discuss with Dr. Sandesh at the end of the presentation. So now coming back to the core topic, introducing the Ziwig Endotest, a non-invasive saliva-based molecular diagnostic test for endometriosis. This cutting-edge test utilizes AI-powered microRNA sequencing technology to detect endometriosis with an impressive 95% sensitivity and specificity, as you can see over here. And one of the biggest advantages is that this test is completely non-invasive. So here's a quick video presentation on how the test is collected. The sample correction process is straightforward. The test will be imported into India from France, arriving first in Mumbai before being distributed across the country based on orders. After collection, the samples will be sent back to Ziwig headquarters for diagnostic testing. You can see over here, this is India and this is France, where we will be importing and exporting the sample. To make this process more clear, here is a graphical representation of the different stages each test goes through. A prescription is required for every test. The saliva sample is collected. The sample is shipped to France. The testing and analysis takes place at Ziwig headquarters, and the result is given via their portal or email to us. This is how the result looks like, with a clear definition of if it is positive or negative. One other thing that we would like to introduce is, as we step into an AI-driven future, we are excited to announce the launch of Endo AI, our AI-powered chat assistant set to launch later this month. Endo AI will serve as a guide for both doctors and patients, providing information about endometriosis, latest information about endometriosis, the Ziwig Endotest, and even assist with connecting patients to doctors and consultants. The data that is powered by Endo AI is sourced from a proprietary database from Ziwig, as well as published research papers out about the diagnostic test. You can also see our website will be coming up soon within the next week, and our social media platforms are currently live if you would like to follow us to spread the awareness and connect with us as well. So how can you collaborate with us? For doctors, join our endometriosis diagnosis network by following us on Instagram, LinkedIn, and Facebook. Help spread awareness by participating in webinars like this one, just as Dr. Sandesh has done today. Just reach out to us via our email, and then we would set up a presentation for you as well. For everyone else, raise awareness about endometriosis among friends, families, and colleagues. If you or someone you know suspects that they may have endometriosis, please reach out to us as soon as possible, and we could move forward from there. Before we move into the questions, here are our contacts. And this is our phone number, our email, as well as our social media handles. But before moving on to the questions we received, I would like to address one significant concern that many of you raised, and that's pricing. We are still in discussion with Ziwig to finalize the pricing for India. However, we fully acknowledge that India is a developing country, and we are committed to secure at the most affordable pricing possible for the Indian market compared to what it is sold globally. With that, I would like to move ahead to the questions we received from the audience. We got a lot of questions come out through the form that you sent out, but we couldn't obviously answer all of them. We have picked a few from there for today's webinar. But if you have more questions, please email us at pwcri@endotest.in, and we will for sure have those answered for you. So these are the 5 questions that we picked out, and we will have Dr. Sandesh answer them for you. So Dr. Sandesh, first question that we have got from our viewers is, if the patient undergoes, will the test result turn negative afterwards?
Okay, a fantastic question. Actually, okay, the answer to this would be Ziwig test, what currently we discussed, is not a like a PSA. I'll give you an example. All our doctors here, and you understand the prostate specific antigen, which is used to actually pre-operative, pre-treatment, and post-treatment, and which changes. This is not so in case of the biomarkers or the salivary biomarkers or the signature which we use. Currently, the papers which we analyzed, they were only for diagnostic purpose. When they will have the algorithms, these signatures for treatment part, then we could actually use them to understand. But currently, there from the logic which I can understand is these are not the genetic, these are epigenetic materials. So I'll just explain you. Suppose you have a house. The house is made up of a wall. The wall is in turn made up of bricks, and what is the most important is the interlacing cement. Okay, so same way you have a human, then you have a DNA, then you have the micro coding areas and non-coded areas. So the microRNAs are the non-coded areas, and they are 98% of the human genome, while only 2 or 3% is the actual genetic material. So when the human genome was launched, they said that, okay, we just have to study this 3% because the rest of the 92, 98, 97 is junk. It was actually the word used was junk for it. But now you can see last year the Nobel Prize was for the discovery of microRNAs. Okay, so you can understand how much information is stored in that junk. So it is just the beginning. So when these junk, which is called as junk, or the microRNAs, they are, like I said, in a silent form. They will act only in cases of dysregulation, either upregulation, downregulation. So they will not change. They will still remain there. So I don't think logically, but of course I'm not a biologist to answer this question actually. That's why I find this question very tricky for me to begin with. is whether it will change at present. No, it will not change, I think, because it is not a genetic but an epigenetic material.
Thank you for the answer. Second question that we have is, do you think the sensitivity and specificity of the test will remain the same in the future? Will it increase or decrease?
Hmm. I think this guy was very vigilant on those 200, and then in 1000 a little bit of specificity reduced. Well, it reduced. Uh, to answer this again, I'm applying the logic, because what I feel is currently you have around 2600 the microRNAs. Okay. So from this 2600 microRNAs, they are analyzing 109 microRNAs which are specific to endometriosis. If you reduce 4 or 5 of these microRNAs, this specificity reduces. So in future, like how the concern is, why would they reduce the microRNAs? In fact, suppose in after 5 years you have 3000 microRNAs in the human body, and you add up 10 more or to the endometriosis, you find them specific to endometriosis. The signature is going to get more stronger. So I feel in future it will get better than actually going down.
Thank you. Thank you for that answer. When will you think, when will this test be available in India?
I think you can answer it better.
Yes, the test that we are in talks with Ziwig, I believe the next 1 month, the test can be rolled out to all doctors and patients in India. We are also looking, we also got one more question in the chats asking how long it takes for the test to be, for the result to come back. We are also estimating that with about a month or within a month to have a answer about the test result as well. The next question that we have is, can this test be used for adolescents?
If you see my presentation, I told you, or the papers, the first paper which they studied was between the age of 18 and 43. So right now, whatever data, the sensitivity, specificity for us was is given is above 18. So for adolescent, they are actually into this new. There was another paper which I showed is the 14 years. They have started registering from 14 years. So unless you have the reports and the same sensitivity specificity, we cannot say that it can be used for the adolescent at present. So it is mainly between 18 to 43 for now. But if the other tests also prove the same signature and same accuracy, then yes, it can start very early. That would be fantastic.
Perfect. Thank you so much.
Because see, most important, this is a very interesting and important question, is because if you allow this disease to progress, what you are actually doing is you are allowing it to become chronic, the chronicity, and once it becomes chronic, it really cannot be treated well. Secondly, we have invited so many ART specialists. They would be better to appreciate that when you allow these lesions to become fibrotic, then they will cause a permanent damage to the endosalpinx or to the tubes or to the ovarian matter. So we should not allow these things to happen in the patients. So I think it should be very, very early. Earlier, the better you diagnose it.
Thank you. Thank you so much. The next question, which will be the final question, is quite controversial. Do you think this test will replace laparoscopy?
I wish it replaces laparoscopy. Yes, definitely. See, I remember when ESHRE gave the guidelines, and they said that laparoscopy is no more diagnostic. So it came as a shocker, because nobody really understood what ESHRE was trying to tell us. They were just trying to tell us is that laparoscopy is not needed to diagnose endometriosis. Okay. There they were trying to tell the questionnaires, use algorithms in the questionnaire, use ultrasonography, improve your ultrasonography skill, improve your radiology, MRI skills, and then try to diagnose it, or you can use clinical biomarkers to go ahead with your treatment plans. So you don't need to wait to do a laparoscopy, prove it histologically, and then start the treatment. You can start the treatment early. That was what they wanted to say. But I would rather now, with this test in Horizon, I would say yes, why do a laparoscopy? Especially now you have asked, will it replace laparoscopy? If you would have asked me, can it replace diagnostic laparoscopy? I would say a big yes. Okay. There is no role now to use laparoscopy to diagnose. But yes, operative laparoscopy, which is needed to actually increase the quality of life of the patient or reduce pain, in that cases the surgery or the cases which have actually skipped and gone ahead into a major grade, severe grade, yes, laparoscopy would still remain. But I really wish we diagnose it early, prevent it from progression, and even the radical surgeries that we are seeing nowadays, day in, day out, that all those things should reduce in the clinical practice.
Perfect. Thank you so much. And thank you for Dr. Sandesh for taking the time from a busy schedule to attend and also present this critical topic and this product that we're bringing into India. And also thank you all once again for your participation and enthusiasm. We received a lot of registrations. We will be reaching out to everybody. If you have questions, please reach out to us. One last thing before we end this is endometriosis month starts today. And if you want to spread awareness, wear yellow and support endometriosis. We will be also sending out an email as a thank you and also sending out the entire presentation and we'll be updating more on our Instagram, Facebook, and LinkedIn pages. Thank you so much.
Thank you,
Thank you.
and congratulations to both of you. As very, very hopeful and very happy that you really have done a wonder for us in our clinical practice.
Perfect. Thank you so much.